Well, hello everyone. I am Dr. Klein from The Fix. Today we'll be talking about forced closure of the sacroiliac joints. And I know you're thinking, well, there's like this pandemic going on, Dr. Klein. Aren't there more important topics that you can get into? Why do you always talk about mechanics, biomechanics, and how we're moving, how we're breathing? Because I feel like these are the foundation of our problems. This is where most diseases come from. It's mechanical stress leading to neurological stress, which is then pathological stress. So if you really want to nip this thing in the butt, start working on yourself. Start working on how you're breathing, how we're moving. Sacroiliac joints are a big part of that, and we're going to dig into that today. So I hope you enjoy the presentation. Right now I'll be just running through a PowerPoint, but as I do some live classes, I'll be taking snippets and inserting this, make it a better video that's got some fuller depth to it so you can see this stuff in action and how to address it either with foundation training or with strength training, both things which I love and think should be walking hand in hand. Also, I'll be kneeling during this presentation because I want to work on my mechanics while I'm taking time to do a video. So if you see me bouncing around, it's because I'm working on my hinging. So health is a responsibility. It's a big thing I've been saying a lot to people. They come at me with something, just throwing that at them because everyone's saying, oh, it's your responsibility. Get your vaccine and to wear 3 masks. Well, is it your responsibility to work on your mechanics and be healthy? So I will throw it right back at you. Let's move on here. This PowerPoint wants to cooperate. Click. There we go. So the sacroiliac, it is the keystone of our foundation. Kind of literally. Talk about the pelvis structure being your foundation, your hips. Sacrum's right there in the middle. It's tied together with lots of muscles. So we're going to think beyond the joint today, and we're going to show you. Well, let me just read my bullet points here. There's a complex array of muscular and ligamentous structures that help support closure of the pelvic bones on the sacrum there. Giving a little hug like those arrows showed on the last slide. So nutation and counter-nutation of the sacrum, that's just its flexion extension, if you will, relative to the pelvis can cause not only pain but dysfunction that affects our entire structure. It doesn't have to move a lot to cause a lot of problems. The more we just throw our center of gravity off just a little bit, leads to the joints becoming hardening and stiffing and muscular imbalance taking over, which neurological stress. And what is even more concerning is how slow dysfunction of the pelvic structure can occur over decades without pain. Always should have water before I do these presentations. Pain is the tip of the iceberg. So with the typical chiropractor saying to point out that pain is the tip of the iceberg. We say it all the time. I've been to the office. A lot of people don't have pain, and we'll take their x-ray, and there'll be lots of degenerative processes taking place, and they don't actually feel it in that area at all, or if it's very minimal, or they have some sort of radiculopathy, or the pain's in the knee or something like that. When speaking of the sacroiliac joint, it's best to describe it as a glacial shelf hidden beneath the water, and sailor, it's going to sink your boat before you knew what happened. Sorry, I had to get a little dramatic, but it's important. When we actually see a little cap of ice above the water, we tend to ignore it as a nuisance. But the SI joint is such a stable structure and protected by so many muscular slings that if you feel the slightest discomfort there, we can safely assume there is imbalance in some of the most important muscles in the body. And we will look at those muscles. So when your foundation has got a hole in it, plugging it with passive treatments will only do so much. Like, well, Dr. Klein, aren't you throwing yourself under the bus a little bit there? As a chiropractor, don't you do passive treatments? Yes, I do. Yes, I do. And that's why I will get very frustrated with people when they're not taking care of themselves, because I feel like I'm doing a lot of work to remove restriction and you're allowing the restriction just to come back. It's like I'm trying to paint a nice picture and you're taking it home and rubbing sandpaper over it. All right, you have to work with me. Chiropractic is a tool, just like the other modalities are tools. They're not going to do all the work for you. Only you can train instability away by strengthening what's weak. I can't strengthen your muscles for you. I wish I could. I would do it. So the core and the keystone connection. Everyone's like, foundation training, it's for your core, right? It's for your whole body. That's why I highly suggest it for your neck and for your shoulders and other things. And I feel like I've had these conversations over and over again. People are like, isn't it just for your core? I have neck pain. What am I supposed to do for my neck pain? This is for your neck pain. Same with strength training. You're not like saying a deadlift is just for your hips. It really works your whole body. It's these whole body movements, underweight, that increases your load tolerance. That's what's so magical about it. It's working your whole body as one. You're training, essentially training your body to move better in life, because we have so many comforts that leads to curses. We've forgotten how to hinge and squat. And I saw a funny meme the other day. It's like, if only people learned to squat to depth, then our society would look like this utopian, beautiful universe. Then if it looked utopian and flat, no, we wouldn't be challenging our hips, because that's our problem anyways. Everything's flat. Flat, and shoes, and sitting. Technology. So I'm kneeling. Challenge it. All right, so the obliques, your lats, your spinal erectors, and your thoracolumbar fascia, which is very important. We'll look at that. Fascia are all bands that wrap the sacroiliac joints or use long levers to hold it in place. See a little diagram here. We have the form closure, which is kind of opening up of these sacroiliac joints. And there's kind of like a deeper SI joint and a more synovial. So you'll have almost like the synchondrosis in your skull, similar to the lower joint, and then more synovial joints. That's what you'll feel pop sometimes, especially if you're the chiropractor. Is that synovial joint that's moving. So, but ultimately, not a lot of motion, but we force a lot of motion in the sacroiliac joint. I'm not saying it can't be closed down, and that can't be a problem either, especially on one side or the other. But forced closure tends to be missing, especially with our hinging motions, our squatting motions, our bending motions. We're robbing motion. Even in yoga, we're robbing motion from the sacroiliac joint instead of training the hips to do it. Nothing new. If you've been to foundation training class, this is what I say all the time. But now we're looking at why and how. So these sling-like muscle groups contribute to forced closure of the SI joint to help support the joint tissue and ligaments. So when we feel pain in the SI joint, it is more likely that the tendons of these muscles are irritated or have tears. So I do various tests when somebody comes in. I lay them down. I'm checking to see, is this a facet joint? Is this an actual sacroiliac joint sprain? And sometimes they're fine with the test, but they have a lot of pain. They might even have radiculopathy, but it might not be the disc, essentially, or the joints of the spine. It could be just all these tendons that are so damaged and inflamed. If there's inflammation, there's injury. If there's pain, there's injury. And we just have to learn to accept that. We're like, and they're like, yeah, duh, Dr. Klein, I understand if there's pain, there's injury. But you really don't. And you don't treat it that way. You just ignore it and you keep pushing through it. If there's pain, there's injury, there's imbalance, there's a problem. It's taken years and years to get there. We have to start changing how we're moving. We have to look at things new. We can't ignore. So tendon pathology, and you can write novels on this stuff. Well, we'll give it a little glance today. So a reactive tendon, which is not rehabbed, would become degenerative over time and leave the joint tissue to battle the imbalance. Reactive tendon means there is probably some pain, maybe not. It might just be mechanically deaf or not moving well, or not moving very well. Doesn't necessarily have to be pain, but there could be just some slight pain. But it's getting there, right? It's becoming degenerative. So collagen tissue will form inside the tendons, and the tensile strength is lost, as well its springing capacity. Tendons are part of the muscle where they attach to the bone, so they should kind of react. They have lots of nerves in there that interact with the brain and how we're moving. So if the tendon is not springing and moving like it should, it's just like it's made of hard plastic. It's just stopped working. It's become rigid. And there'll be good fibers around the rigid areas, almost like little balls of Play-Doh are stuck inside your tendons, and they just don't react as they should. So then when they don't do that, other things get damaged, including the joints. So we can have these degenerative processes take place in tendons without any pain until the tendon ruptures without even any really cause. You hear this all the time. It's like, got up, just walk, and my Achilles tendon just snapped and pulled off the bone. I hear this all the time, especially with lower back injuries and sacroiliac injuries. I turn funny. I didn't do anything. I've been doing what you say, doc. I've been doing the foundation training. And I'm glad you're doing the videos. Come to class, make sure you're doing it right. That's my job there, is to try to really help you make sure you got the sacroiliac joint working right. It's closed, you're motioning from the hips, not your low back. So the next few slides, we'll look at what muscles support stability of the SI joint. Pictures! All right, so here's Phil, and we'll pull out Phil for the demonstrations and some of the live videos, and I can see that as I've pulled this from one computer to another, the pictures are covering some of my font, but that's okay. I will get through it. Longitudinal sling. So the longitudinal sling, we've taken Phil here, we've taken a TheraBand, we've just kind of covered that particular area. So we have the sacrotuberous ligament kind of connecting here to the thoracolumbar fascia, and then we have our spinal erectors, which are the big ones. There's 3 different bands of those, and we will look at those. I love spines, if you want to remember, if you're studying for your boards. So multifidus here is the deeper layer, so that'd be the spinalis layer, which is formed of the transversal spinalis muscles, which are these deep grooving muscles here in these on either side of the spinous process. And then we'll have the iliocostalis, which is the outer layer, and the longissimus, and then spinalis, which is more central. So the different layers, and then the thoracolumbar fascia is not just one big band of fascia. Some people think there's 2 or 3 layers of this fascia, which kind of separates. So you'd have this longitudinal sling. You could have thoracolumbar fascia, which your lats attached to. If you ever look at just some plain anatomy, and I think we'll look at the lat here in a second. Just you have the lats coming down, it's tendon inserting into the thoracolumbar fascia, which creates this triangle shape around the sacrum and the SI joint, just something that would hold it together. So very stable joints, lots of muscle going in there, and we'll look at even more here in a second. But when we have pain in either of these SI joints, we're assuming, okay, now the lat and these muscles, the posterior chain is failing. Let me read my slides before I move on here. So some call this the posterior chain. I just did. Its engagement helps resist the posterior pelvic tilt. So that's the tucking of the pelvis, or the butt wink, we call it sometimes, when you're doing your squatting really deep, and the pelvis will tilt underneath. Not necessarily a bad thing, but if you've got some sacroiliac joint problems, or you're always relying on that tilt, or you're really just kind of rebounding out of your squats with heavy weight, this could lead to pelvic floor issues and ultimately not getting the actual mobility in the hip that we truly need and desire. Posterior pelvic tilt that often likes to pull the SI joints apart. So that's the problem with posterior pelvic tilt, is it will try to pry these SI joints into more form closure instead of force closure. So we need to inflate, I don't know exactly what I'm trying to say here, but we need to inflate the thoracolumbar area to prevent this, especially when you're doing a squat. These people look kind of breathe in big and heavy, they'll expand the diaphragm in all different directions, not just forward, but wide and back. That'll stretch, and that's the same position you'll notice we'll do in foundation training with measuring stick hands, is we're inflating the thoracolumbar area. And you can really feel it. Once you kind of, we'll look at the pictures, you can like, oh yeah, that's what I feel when I'm doing that. That's setting you up for your heavy lifts. All right, so multifidus attaching the sacrum and ascending the whole spine. That's a big part of that longitudinal sling. And we have the deep layer of the thoracolumbar fascia. Like I said, there's multiple layers of it. And the long head of the biceps femoris attaching to the sacrotuberous ligament. So we'll have a better picture of that. But pretty much your sit bone, which you might be sitting on right now, that's where your sacrotuberous attaches. And you can think of that just kind of like an extension of your hamstrings. Right? Hamstring muscles, well, 3 of them attach here to the sacrotuberous. You have your biceps femoris as well, the short head, which is more lower distal shaft of the femur, which goes down to the knee, which does not come up here, but big old band kind of joins the sacrotuberous. We got the glute, and then we're going to get into this oblique sling, the posterior oblique sling next here. So thank you, Phil, for your, and I also like this down view. You kind of see the inside the joints here, and look at these grooves. So there's lots of muscles that will attach here. Anytime they got like a rough area in a bone, okay, that's where a tendon or a ligament is attaching. So here we probably got obliques coming in, this thoracolumbar fascia is all connecting here on the SI joint. So you can see how it would help to close this down if there's gapping, and if I'm feeling, I'm touching here, there's sprain here, or even as we get into the lower lumbar spine, we could have these facet joints, which allow for your flexion, extension, and a little bit of rotation in your spine. It can be damaged by failure of the muscular structure. So the TLF, the thoracolumbar fascia. So you can see the lat here forming its tendon forms in, and we got this big triangle. That's right where your tailbone is, where your SI joints are. And it's just one layer what we're seeing, right? It's kind of even the traps come down, they form into that, and then we'd have a lot of those bands of muscles that we just talked about deeper to this. So injury in this large sheath of tendon and fascia if muscle balance is great enough or has been present for a long enough time. So we have 2 or 3 layers that separate the back muscles. It serves as a hub that intersects into the sacroiliac joint and covers the sacrum. So the deeper layer separates the QL, quadratus lumborum, and the psoas. We're always talking about the psoas in foundation training. Very important muscle. Probably should talk about the QL more. It's also very important. But it separates from the spinal rector muscles, and then there's an outer layer which separates that from the lats, right? Some of this information I'm pulling from this link here, so you can go there. So, spreading it before we lift, or even just bending. You don't have to do it all the time, just preparing. The more you do it and train your body to do it, you'll do it unconsciously. And you'll protect your back. You won't always be bending from your lower spine all the time. All right, so let's look at kind of what we already did. We get this anterior border of the ilium, which means it's just more forward. And we have all these attachments. So already kind of named those. We'll just move on, just giving you another little picture there. There we go, posterior oblique sling. So we got Phil over here. Took a little TheraBand. If you look at this trochanter bone, we can see it over here. It's your trochanter. What attaches there? Well, lots of things, but the big one is our gluteus maximus, right? So that comes there, and then what we mentioned before, the biceps femoris, kind of forming into our sacrotuberous ligament, which is just often very tight, either on both sides or one side of people. If I'm ever digging in this lower area, and you're like, it's kind of close to things, Dr. Klein, why does that hurt so much? Most people aren't like necessarily shocked, just like, why is that sore? Why is he in there? I'm really sorry about this font here. I should have checked some of this. Every time you transfer a PowerPoint to another computer, just the pictures are off. I'm surprised the arrows are still pointing relatively to the right areas. Lat muscle, we just showed that thoracolumbar fascia and how the lat comes up, really connecting the hip to the shoulder. So we have this sling, this connection. I could even think about the hamstring going down even farther into the knee. It's just a longer lever, this big X that's coming in. If you've ever done the 8-point plank, I'm always telling you to think of a big X. This X pulling into your abdomen, not lifting yourself from the ground, but squeezing the ground away. You're essentially activating this X to work. So you might notice one side or the other, a little shaky, a little harder. Sometimes when you're engaging something, it just feels like something's out of place, and it probably is. Your bones and your ribs aren't lined up as they should be, but we can pull them back into place doing this. So not just your chiropractor putting them back into place, because just put it back into place. We haven't created the strength and stability for it to remain there. Big X intersects the tailbone, hugging those iliac bones to the sacrum, I'm going to guess that says. So we get the arrows pointing to those muscles. So that's our posterior oblique sling. And then we have the anterior oblique sling. So that's just on the front. And this is probably what most people think of. Core, right? Work your core, you can work on your core. I think I rant a little bit here, so let's read this. A strong core means a strong back, yes. So I've known many supporting a six-pack walk in the office that have debilitating back pain. So just don't think, man, strong core, strong back. I'm going to do lots of crunches. And it's the same problem people have with like, I'm overweight, I'm obese, I need to just hit the elliptical until I die. Or walk. Walking can be just as devastating as lifting heavy in the strength training. A lot of times it's not your heavy lifts that injure you, it's the little things that injure you over time, right? If you're not walking right, you're not using your hips, and your SI joints are doing all that motion, they're not supported, they're not closed down, that's injury over time. It's little micro traumas. So don't lie to yourself. You got to train yourself how to move. And a lot of times lifting, the heavy lifts especially, force you to have good posture. Put weight on you, your body automatically inflates. You automatically lift up against that weight. Your feet engage, your hips engage, everything engages. You're like, oh, there's something here. You got this neurological stimulus. There's this weight on you and your body's resisting it. It's expanding. Your breath is going to be different. How you move is going to be very careful and slow because you're suddenly aware. If you're just in there, got light weight and you're doing deadlifts, just like 40 kilograms on each side and it's super light, you might be more likely to damage yourself there because you're not attacking it as you should be. The more heavier we attack things, the more stability will be maintained. And I'm not saying just go lift heavy on your first day. I mean, you still have to train. And that's what's great about foundation training is you're learning to find resistance inside your body, even without weight. A lot of times I like people to imagine tension, imagine weight. And that helps them. And then you can go out, start throwing kettlebells around. So we can't just crunch our way out of pain. We need to train these muscles to work in a decompressed state. Decompressed, that's load tolerance. Same idea. We're expanding that thoracolumbar fascia. So the position of the spine and hips matter. To lock or to unlock. It is common for one sacroiliac joint to be closed and the other to be open. And we find this with rotational distortions and muscular imbalance in the slings we just mentioned. So both can be unlocked or both can be closed, causing different problems. We are either looking at a hypermobility with posterior pelvic tilt or a restriction in the anterior pelvic tilt state. And I am a person that gets very frustrated with pelvic tilt. And it's something I kind of, if we go way back, like 4 years, 5 years when I first started doing videos, it's all about pelvic tilt. And people get so focused on, like, I know I'm posterior pelvic tilt, I have to fix this. Or I know I'm anterior pelvic tilt. So if you just start decompressing, your tilt tends to find its way out of there. And if anything, if you really have a tilt problem, I'll address it after you're decompressed. Because you always want to address it in a decompressed state. Because if you're just tilting and then trying to decompress, it doesn't work. And often, especially with posterior pelvic tilt, the body will adapt. It does this sway back thing, which we'll look at in a second here. But it will tilt posterior, which is, if you're in a really decompressed state in your posterior pelvic tilt, that's kind of where you should be, where your weight's back. But this is very uncomfortable. So people let their hips slide forward, and it'll look to your average observer that you have anterior pelvic tilt when no, you actually have very, very shortened hamstrings and you're in posterior pelvic tilt, and you probably have sacroiliac joint instability, which leads to instability in the rest of your structures. So arthritic changes can occur from either too much force closure or form closure if stability is not achieved. Here we go. Center of gravity. So this is the first one I was talking about, the posterior pelvic tilt. She doesn't want to have this super tucked and engaged glutes while her weight's back in her heels. It's hard. The body doesn't like things that are hard. It likes to use the spine to bend and extend and be in a compressed state because it's easier. You don't have to use as much muscle. But breathing's not so good here, right? Shoulders are really turned in, and we got the reverse curve going on in the neck. That's why I say, how could foundation training affect your neck? How could this not? How could this not affect your neck? If your hips aren't right, how's your neck supposed to be happy? A lot of people do this too, though. I call this the runway models. They're trying to get back there, and they're trying to fix a neck problem. Gonna cause that problem there. And it looks like she's got some problems of her own too. It's funny when people have like a certain posture type and they're trying to show another posture type. Good example, you can see it. But when we get her into her state here with the lordosis, a lot of people think this is lordosis because you look at the spine. It's going to look similar, but it's going to be more like an S shape, where this is going to be an increased C shape. It should be a subtle C shape anyways in the lumbar spine. But even in her neck here, her neck curve is still flat and back. Both of these are really squeezing the rhomboids and really driving the head back. So neither of these are correct posture anyways. They're both bad. So sometimes they'll call this anterior pelvic tilt or athletic hip. So more quad dominance, more hamstring dominance, but even that is just painting too simple of a picture. And if we look at the thoracolumbar fascia in either of these states, if we got our arms out of the way, it's shortened, it's compressed. And everyone likes to be expanded in the front because that's where the cartilage is in our ribs, so we can breathe easier, but that kind of closes down the back of the spine. Closes down all these, it tightens all that area. So anterior pelvic tilt will tend to have closure, but we can have degeneration there if it's closed or closed too much on one side. So too much of a good thing, right? Is also a problem. So as anterior pelvic tilt increases, the center of gravity shifts forward. And we almost said the same thing here. Shifting forward or backwards, depending on how far they go. Getting some of the weight out of the toes and into the heels can effectively pull the pelvis back beneath the spine as the thoracolumbar fascia becomes engaged, so the sacrum moves with the pelvic structure without nutation. And we'll dig into that a little bit more, definitely show that in class. So posterior pelvic tilt will force a swing of the pelvic structures forward. So that's the first picture there. Essentially, we're expanding the back. We're expanding the sides of that rib cage and our lower spine too, because there's no ribs down low in the lumbar spine. It's a kind of an unprotected area. So we have lots of muscles to do it because we don't have a lot of joints to rely on. So we need to strengthen the muscles to do that work instead of just relying on a few lumbar joints and discs to do everything for us, because eventually they will fail. And there they are, those bottom three, L3, L4, L5, sacrum. So we have our psoas. I know, lovely drawings by Dr. Klein. Not so great, but I like to draw. It helps me learn. And we have iliacus. So iliacus is sitting on that ilium bone. And both of these muscles, they form a tendon which attaches to that lesser trochanter. So if the lumbar spine and the hips are not moving and we're thinking like an isometric engagement, that's going to help force closure. Because then the spine's not really working, and then these muscles together act like a bowstring. So it tightens and the spine itself shifts back. The whole structure comes back. And that pulls the weight into the heels, forces the feet and your arches to activate for once in your life. Because we just lack our feet. So many nerve fibers. They're like our hands. Just sensation is such a high thing here. But we just it's like wearing really thick gloves all the time. It's just going to affect your hands. And you're not going to be able to move as well. You're not going to be able to grip and grab as well. And that's kind of what we're doing to our feet. Put them in these tight shoes. And we walk on flat, hard surfaces all day long. We don't have gravel and sand and grass to grip and grab like we should. So then our hips fail. And then our SI joints just are forced to do all the motion. Lumbar joints forced to do all the motion. Hips are not. So Iliopsoas, you'll hear it's called the major stabilizer of the lumbopelvic region. That bowstring effect is supposed to hold it all together, protect it. When the femur and lumbar spine are fixed, they don't move during Iliopsoas activation. So if you think about, like, Iliopsoas can kind of raise, if you bring your knee up to 90 degrees and go a little bit higher, then it's going to activate it. And that's people like, well, that's majorly what it's for. No, that's not its whole job. It's like a rotator cuff. You can think about it like a giant rotator cuff. Its job is to hold the hips into the socket, just like the rotator cuff holds your shoulder in the socket. So it's not always protracting or shifting in a lot of internal external rotation. It's being held tight. We call that proximal strength and foundation strength. Proximal strength, distal range of motion. Keeping the shoulders close to the body, keeping the hips close to the body, trying to move in that state, in that decompressed state. So the iliac portion will contribute to a locking of the SI joints as long as the pelvis is not allowed to tilt. So sometimes we'll activate these muscles we're trying to get in our decompressed stance, and we'll just tilt or open up the SI joints. So we want to close them down, hold them closed, and then activate these muscles. And that's when we get the structural joint change. Degeneration. So we can have sclerosis from a locked and chronic forced closure on one side. We could say the right's really closed, and sometimes the left is opened. So we'll see the left is got a posterior, externally rotated ilium, and be an anterior, internally rotated on the right. So it's shifting, and that causes the spiraling of the spine. And sometimes that's even from the neck. The neck is out of place, then chicken or egg, what's causing it? So hypermobility leading to a sprain, strain injuries. That is it joint or muscle that's being injured that occur often or fail to heal. So we have this injury that keeps coming back over and over and over again, or just never really leaves. It kind of feels better, and it comes back. It's like the same side over and over again. Or it's this big injury, and it's usually not the case. It's like, man, I got hit by a car, and I got this bad injury. And sometimes there's already an injury there, and then you have this impact force, and it's already set up to be injured. That is also possible. So immobile joints tend not to bother us. Immobile, not moving very much. They tend not to bother us, but can cause issues elsewhere. So this is the whole two frames of mind. That's when I first started going to chiropractic school, and I was first a chiropractor. I was like, yeah, the restricted joints, they don't move. My job is to move them, and that will help the instability elsewhere in the body. And that probably does happen, but not as much as I would like or have learned that happens. So I tend to blame instability. There's a joint that's unstable. It's got too much motion, and that's causing restriction on the other side. But it can definitely work both ways, and they both play off each other. So we may even be able to blame a restricted SI joint on the unstable one, right? So kind of reverse psychology there. So the body will respond to an unstable joint after a prolonged period of time by adding cross-fiber adhesions, which are rigid, non-spring-like tissues. Kind of talked about these before, like these little donut hole shapes in the tendons that result in very stiff mechanics. Like I said, the idea is like you're mechanically deaf. You can't feel, or to be deaf isn't the right word, but you can't feel the vibrations, and your brain isn't connected to its proprioceptive mechanisms as it should be. And another word for this is mechanoreception. So not just pain, especially some of the smaller muscles in the body have very, very high levels of mechanoreception, but not so much nociception, which is pain. So piriformis versus glute, we're almost done here. Just looking at some more concepts to help bring this home. Some things we'll be talking about in class. So we can have the glute max, another Dr. Klein drawing here. Pelvic bone, sacrum, even attaching to that insertion of that sacrotuberous ligament, which is coming down here, kind of coccyx area, sacrum, running down to your ischial tuberosity, and then continues on with the hamstrings, biceps femoris, which is the outer muscle. That's why we named that one. All hamstrings are important. Then we have piriformis. And we bring up piriformis because it's just everyone knows about the piriformis. It's just piriformis syndrome. It can pinch on your sciatic nerve. It could make you think you have a disc problem. It's actually a muscular problem. Everyone thinks it's tight. And oftentimes it's not the tight muscle that's the problem. It's the weak muscle. I think this arrow was out of place. I'm like, what are you pointing to there? I think this is supposed to be up here. So it's kind of showing how the trochanter, since it attaches to this trochanter bone here, is pulled up and in. Very sorry about these arrows. It looks so nice. And I had some nice 3D graphics that just didn't transfer. Some little movements, little actions. Oh well. But we'll see that this sacrum on the right side will rotate forward, as the piriformis actually attaches anteriorly, kind of more on the front of the sacrum, where glute is posterior, right? So they can create the spiraling effect of the sacrum. And if your foundation is spiraling, we can assume, not to imbalance in these muscles here, like in the microscope, literally like looking at them, but what about everything else? The lat muscles, the hamstrings, everything that crosses and converges here to help bring stability to the SI joint is compromised. And we have so many nerves coming out here. So it could just be irritation, inflammation that's causing your nerve pain, or it could just be maybe just have pain here in the thoracolumbar fascia, or maybe the deep sacroiliac joint pain. Usually, if you have deep sacroiliac joint pain, we could just assume we've already had a lot of pain and breakdown of the tendons and thoracolumbar fascia for years and years and years. So the example would be if we have a tight piriformis on the right, we'll end up with a anteriorly rotated sacrum on the right side, which will open that sacroiliac joint, just giving you a concept, closing the left. So this will be more anterior pelvic tilt on the left, posterior pelvic tilt on the right. And sometimes people aren't so twisted in the lower back. It's just general stretch. And sometimes I'll call this traction sciatica. Don't look that up. It's just a Dr. Klein term. Is when there's so much tightness up top. Someone's like a shoulder breather, and they'll have so much pain in their lower back. And I'm like, your shoulders and your neck, which they don't have any pain in, are just so rigid and tight. It's just pulling on your spinal cord, pulling on all these nerves that are going down to your legs. So sometimes we'll have instability on one end of the body due to high restriction and immobility, overuse on the other end. So that you can think of that as more of a, is this an ipsilateral problem or a bilateral problem? Is it on both sides? Or are we looking at something that's on one end of the body versus the other end of the body? A lot of different things. We can all address this with working the body as one, training the body to move as one. So a crunch tends not to be a whole body exercise, really focusing on one muscle. And that's why I'm not a big fan of, it's not that you can't use them, but like machines at the gym tend to cause problems. And there's something about challenging your balance, picking up a barbell, doing some lifts. Deadlifts are great, snatches are great, cleans are great, back squats, lower back squats, front squats, all great stuff. Hip thrusters. Let's talk about sacroiliac joint closure and the hip thrust. So important, especially adding weight. All right, so the glute max, we'll just read it anyways. Glute max will pull the apex of the tailbone in a posterior lateral direction, while the piriformis will pull anteriorly on the sacrum. So opposite directions, right? So which one do we blame? Both. Its attachment to the sacrotuberous ligament will help connect the posterior oblique sling. So that's what we said before, that glute max engaging, crossing the sacrum, big X. Piriformis attaches on the superior, slightly anterior portion of the trochanter, that guy over there, anteriorly rotating the sacrum on activation, and if this arrow is where it should be, it kind of pulls those hips up. There's one thing we'll talk about in class and we'll show is pushing those trochanters down in our decompressed stance, and that's our hip hugger position. I will show that, so we'll look at that. So strengthening of the piriformis is needed on the more anteriorly rotated ilium, and the glute release is needed on the ipsilateral side. Let me make sure I said that correctly. Strengthening of the piriformis is needed on the more anteriorly rotated ilium. That is not correct. That's opposite. So if it's tight, it's going to pull it anterior. So the more posterior pelvic tilt, so the side where you would have a strong glute, often is the strong piriformis. So completely ignore anything I'm saying here. But the point is it's opposite. So the muscles in red here are showing what's tight. So if this is tight, it's going to pull it anterior, which means the one we haven't drawn on the left will be taut, overstretch. And sometimes what is taut is more likely to compress the sciatic nerve than the tight one. I'm typing this stuff up in between patients, so sometimes I'm not paying attention. I'm sorry. That's why I'm reading it. And that's it. Thank you for staying with me. I'll be sure to insert lots of other videos into this, and please ask questions if you're confused. This is a lot of information. Thank you very much, and have a great day.